Hello, everyone, and thank you for joining us on day 3 of Devex's coverage of the World Health Assembly. My name is Vince Chadwick. I'm the Brussels correspondent here at Devex, and I'm joined by my colleague, Lei Ravelo in Manila. Jenny, it's great to be speaking with you again. I hope you're surviving this intense week. You seem to always be online these days, so I hope you have a good rest after this week as well. Our subject today is the future of health systems. We've got a set of great panels coming up with our partners Gilead. We've also got a section on the future of health technology in low and middle income countries to come. And we've got a panel on strengthening the WHO and particularly on financing the WHO. And I wanted to ask you, as someone who follows the organisation closely, how close are we to a breakthrough in how the WHO is financed, given that this is a topic that is not new since COVID, but perhaps COVID has brought that to everyone's attention?
I mean, there's been another, set of increased calls for member states to, increase their assessed contributions to the WHO. But again, you asked, are we close to a breakthrough? Everything is, reliant on, the countries themselves. Currently, there's a member state-led working group on sustainable financing, and they were created last January to kind of really look into, how to address the unsustainable financing of WHO. And I'm excited because we one of our panelists later today is Mr. Björn Kümmel, who is the chair of that working group. So something worth asking him about.
I remember covering a panel with Björn last year, listening to one of those committee meetings, and he was speaking on behalf of Germany. And so indeed, it's going to be interesting to hear from him today. I mean, one of the ideas being thrown around is this idea of a replenishment model, as we would have seen with Gavi and with the Global Fund and things like that. But it seems like not everyone's convinced that that would work in the case of the WHO.
Yeah, the working group did publish their report they had 2 meetings since January and submitted a report to the WHA this week. And it says there that they looked into the financial models and replenishment models of Gavi and Global Fund. But then, some member states, according to the report, I don't think that the replenishment model would work for the WHO. They did not say why. It was not clarified in the report, but yeah.
Something to perhaps get into with the panel later. But before all of that, we've got a conversation with Richard Hatchett, who's the CEO of CEPI, the Coalition for Epidemic Preparedness Innovations. What are you two hoping to discuss?
Well, of course, as you know, CEPI has played a key role during this pandemic, helping advance the development of some of the vaccines now being administered globally as part of COVAX. But also, I'm interested to ask Dr. Hatchett about the COVAX Manufacturing Task Force and how that's sort of addressing the current challenges we have today, the shortages in supply of vaccines.
I mean, I've covered the Global Health Summit on Friday, and there a lot of the talk was still about money. Although there's beginning to be this shift, obviously, towards sharing of doses themselves. So again, this emphasis on supply rather than financing, as we would have had in the past year with COVAX. It'll be fascinating to follow that conversation. I might let you guys get to it. And before I do that, I'll just remind our listeners that next Tuesday, Jenny will join us for a conversation with the reporters at Devex about what we've learned from this year's World Health Assembly for Devex Pro subscribers. And you can sign up for a free trial of Devex Pro on our website and give us your thoughts too about what you've been following over this intense week. So with that, I'll be back later, but Jenny, I'll leave you and Richard to start your conversation. Thanks very much.
Thank you, Vince. Hi, everyone. So again, I'm Lei Ravelo. I'm the Global Health Reporter for Devex. And with me today, I'm really pleased to have Dr. Richard Hatchett. the CEO of CEPI. As you all know, CEPI, the work of CEPI during this pandemic. But just a brief history is really, CEPI is a very young organization, launched in 2017. Conceived from the West Africa Ebola outbreak, and its mandate is really advancing, accelerating the development of vaccines for infectious diseases. But then COVID happened, and as you know, as I mentioned earlier, CEPI has played a key role in advancing some of the COVID vaccines that a lot of people have received today, but there's still a lot. But first of all, Dr. Hatchett, thank you for joining us today.
Sorry about that. It's a pleasure, Jenny. Thanks for having me.
Well, I think my first question would be what everyone would want to hear, really. And if you can give us an update on the vaccine supply to COVAX. As you know, everyone's really, there are anxieties, there are questions when countries are going to get their doses.
Sure. No, let me say that COVAX is working. We have now delivered over 70 million doses to, I believe, 125 countries and participants, who are working with COVAX. But that is significantly behind where we had hoped to be at this point. And the reasons we're behind are that the initial supply for COVAX, a very substantial portion of that supply was emerging from India. And of course, the timing of the terrible outbreak in India, the Indian manufacturers understandably are allocating their supplies to addressing the needs of the Indian population, and that has resulted in delays in delivery to COVAX, and so we are not where we had hoped to be, but we are working obviously both with our partners in India, particularly the Serum Institute, but with our other partners who are manufacturing in other locations to see what we can do to accelerate the availability of doses.
You mentioned about the Serum Institute, and the CEO of Serum Institute just recently, mentioned that they may not be able to restart the supply outside India until the end of the year. Where are you now looking into specifically? Are there other vaccines that you hope will be available soon?
Well, there are, and as I said, we are still working quite closely with the Serum Institute, and we hope that the availability of supply will be restarted earlier, much significantly earlier than the end of the year. But we have to continue to watch the epidemiology in India unfold and the needs of the Indian population. But just within the last 10 days or so, COVAX has signed agreements with Novavax, with Moderna, and with Johnson & Johnson that will make available well over 1 billion doses of vaccine, many of those, hundreds of millions of those, within 2021, and a portion of those, spilling over into 2022. We're also, working with a number of high-income countries that are supporters of COVAX, and we are promoting the sharing of doses. Countries that are well positioned with respect to vaccine supply, we are urging them to share doses now, and to make those doses available as soon as possible. And we've already had, I believe, 8 or 9 countries that have signaled that they will be sharing doses, including recently the United States of America has announced, on top of the 60 million doses that they had previously discussed sharing with the rest of the world, an additional 20 million doses. So that, we've seen the contributions from Norway, for example, recently, from Sweden, from France and Spain and Portugal and others, and we certainly want to encourage those.
Just a quick follow-up on that, because a lot of low and middle income countries, they need the vaccines now. So, are any of those vaccines, have they started to come in? When are they? Do you have a timeline when countries would be able to receive them? And just a quick one for countries that, for populations in countries that receive first dose of the AstraZeneca vaccine, how are you kind of feeling, making sure that they'll receive their second dose on time?
Well, I think there will be delays for some countries. Many of the countries used up the first allotment of doses and provided first doses to a larger number rather than reserving a portion of those first doses to provide second doses. And epidemiologically, that probably is a good strategy based on what we are coming to understand about first dose efficacy. And as you know, even in some high income countries in the UK, where I'm based, they extended the dosing interval for the AstraZeneca and the Pfizer vaccines as a way of increasing population immunity quickly, and that seems to have worked quite well in Britain, where cases are subsiding, but many people still have not received a second dose of vaccine yet. So in terms of the dose donations, I believe the donation from France, for example, was very quickly converted into a shipment of supplies to Mauritania, if I'm remembering correctly. We're working very closely with the other countries. We're trying to put in place mechanisms that allow for very rapid, if a country makes a decision to donate doses, that we can take and process that donation very quickly and move those doses out to countries that need doses as quickly as possible.
Now, I also know that CEPI is part of this COVAX manufacturing task force. Can you just tell us a bit about what the aim of the task force is, and how will it sort of address the current supply shortages that the world is facing today?
Well, I'll step back slightly and say that we from the very beginning, from early last year, we recognized that when vaccines first became available, by definition, they would be characterized by scarcity initially, and the real challenge is to shorten that period of scarcity to the greatest extent possible, and to make sure that the most vulnerable populations are able to access vaccine. In late February, or even in maybe in early February, we began to have concerns about the manufacturing supply chain. And we actually co-sponsored a meeting with some of the industry association partners at Chatham House in early March around what we saw as emerging challenges within the supply chain. That companies that were manufacturing vaccine didn't have access to the raw materials and the critical consumables, the plastic bags, the filters and culture media to actually produce vaccine, and thus the manufacturing capacity that we have would have suboptimal output. So we've been focusing on this for a while. Ultimately, we've recognized that there are a number of potential barriers to manufacturing across the entire life cycle of the manufacturing process that we could potentially address. The first and most pressing, most immediate, with the highest payoff in terms of increasing vaccine doses in the next 1 to 3 months, is fixing those supply chain problems. But there may be manufacturers who need access, for example, to fill and finish capacity. And COVAX has reserved fill and finish capacity that we can match with partners. In a longer term frame, one of the problems I think that we are seeing in terms that have produced the inequitable distribution of supply that we are observing is that vaccine manufacturing capacity is inequitably distributed right now. It's in North America, in Europe, in China, and in India, all of which are very large populations that can absorb a lot of vaccine. Very, very little vaccine manufacturing in Africa, limited amounts of vaccine manufacturing in South America and in other regions. And so ultimately, I think looking towards the future, while this won't produce increased vaccine supply in the next month or 2 months or 6 months, I think we ultimately need to see more equitably distributed manufacturing capacity globally. And that also falls under the remit of this task force.
Have you identified, particular countries or regions where you see the task force can help build these capacities for the future?
For the longer term. So WHO is taking the lead on that effort. They've put out a call for a request for information. Essentially, they're asking countries that are interested to identify themselves, asking partners who might be willing to transfer their technology to identify themselves as well. The African Union has developed an African vaccine strategy, which includes a focus on manufacturing, and they've identified 3 countries that they have put, at the head of the priority list in Senegal, Rwanda, and South Africa. And I think, we are eager to work with regional partners like the African Union, and to work in concert. We'll need the financing institutions, we'll need the local and regional political will, and of course we can bring a great deal of technical capability and our contacts with our industry partners to the table. It's going to take all of those sectors working together for this to succeed.
I'm curious about timelines. How long do you envision this? You said it's not going to happen next month, in the next few months, but how long it will take for us to see these capacities available in these countries outside North America and outside Europe?
Well, I would differentiate between 2 problems. I mean, there's the problem of securing doses now for COVAX and for global distribution to address the pandemic needs now. And there are aspects of the task force, focusing on, as I said, on the supply chain and on some of the matchmaking between partners that have the potential to increase vaccine supply really within the next couple of months or even 6 months. Efforts to build new capacity, those are long-term efforts. They will take years. I'll give you an example. I think it's a relevant example. WHO supported the Global Action Plan to increase influenza vaccine manufacturing. This was because of concerns about pandemic influenza. That program extended over a decade, actually, to transfer that technology to manufacturers and to help them build their workforces and to build capability to produce. I think they worked at one point with up to 12 different vaccine manufacturers in different locations around the world. Ultimately, about half of those were successes and are continuing to this day to manufacture influenza vaccine, and about half failed. In aggregate, that increased the manufacturing capacity for influenza vaccine by about 1 billion doses a year, which is terrific. But that shows the scale of investment and the need for an enduring commitment to these projects. Now, I think in the current circumstances, the urgency in the middle of a pandemic is much greater, perhaps, than it was for that previous program. So we're hoping those timelines can be compressed. But I think realistically, we're talking about years to stand that capacity up, and it's going to take not just investment in building facilities, but also investments in people, in workforce development, investments in regulatory capacity building, and it will take sustained political will from the countries that are receiving the assistance to build this capacity, and sustained commitment from them and from the donor partners for this to succeed.
I think lastly, what's next for CEPI? We're still very much in this pandemic. What are you going to be be busy about in the next few months?
Well, CEPI's role through the pandemic has evolved. In the first couple of months, it was really important for us to, ignition, to just get these vaccine development programs going. Over the last year, working with Gavi, WHO, now UNICEF, we've been very concerned about access. At this point, and we've made very important contributions to R&D and through our R&D agreements to securing access commitments for the COVAX facility. Looking towards the future, at this point, I think we need to be thinking about, there are lots of vaccines based on the currently available technologies addressing COVID. We are still interested in making investments to have vaccines that are variant proof, that are broadly active against many strains of COVID. We ultimately think it's important for the world to at least attempt to develop broadly acting, broadly protective coronavirus vaccines that protect against COVID, but also against other potential future coronaviruses that might emerge and cause other pandemics. As we sort of move beyond the pandemic, hopefully in the next couple of years, we've established a major goal for us is to dramatically compress vaccine development timelines from the 326 days from sequence to first licensure that we saw last year with the Pfizer vaccine to as little as 100 days. We think pandemic risk is going to continue. To address that risk, we must compress those timelines.
I think we're very much looking forward to that ambitious goal, and it would be really a big help to the world and a lot of populations in need of vaccines that we don't have in other diseases as well. Thank you so much, Dr. Hatchett. It's been a pleasure to have you with us today.
Thank you, Jenny.
Well, good day, everyone. I am Lei Ravelo, Senior Global Health Reporter for Devex. Thank you so much for joining us today at a very timely panel about strengthening the World Health Organization during the 74th World Health Assembly. The WHO has been, on the forefront of tackling the COVID pandemic, but in doing so, it also has faced a lot of scrutiny, and there have been a lot of calls for reform. Member states of the WHO have put forward proposals to strengthen the organization, but also different panels and committees. Today, we're going to discuss some of the proposals similarly raised by different governments, but also different committees. And I'm really excited because we have such a brilliant panelists who've agreed to join us today to talk about these proposals, but more importantly, how we can make them happen, how we can move forward with these proposals. All of them really do not need a lot of introduction, but let me just briefly introduce them to all of you. We have Amanda Glassman, Executive Vice President and Director for Global Health Policy at the Center for Global Development. We also have with us Suerie Moon, Co-Director of the Global Health Center and Professor of Practice in the International Relations, Political Science Department at the Graduate Institute in Geneva. And lastly, we have Björn Kümmel, Senior Political Advisor on Global Health Affairs at the German Federal Ministry of Health. Björn is part of the WHO Executive Board and currently chairs the member state-led working group on WHO sustainable financing. Panelists, welcome and thank you for joining us today. So right on. So there's a lot of calls to strengthen WHO over the years, but again, during this pandemic, in one of my interviews, one of the experts asked me, what kind of WHO do countries want? And I guess for a start, I'm going to tweak that question slightly and ask each of you, what kind of WHO does the world need? Perhaps I can start with Amanda.
Well, I think first, we need a World Health Organization that has voice and independence and the ability to set scientific standards and to check the quality of their implementation in countries at all levels of income. So that means not just, Malawis of the world, but also the United States and Canada and China. And that sort of global independent mandate really is what makes reform so difficult because in some respects, the WHO was built to help with this idea that infectious disease burden is mainly a problem in low and middle income countries and is not a major threat in the high income countries, and that therefore the tools that the WHO had did not need to be effective in those high income countries. Well, we've seen differently. So we need to retain the value added in low and middle income countries, but we also need to think about how the system works in the high incomes.
Suerie?
Thanks very much. I really agree with what Amanda has been saying on the importance of an independent WHO that can operate at arm's length from the political pressures that we know it will face from member states and from others, especially in the middle of something like an outbreak of infectious disease. I would add on top of that that we need WHO to play what we sometimes call the stewardship function over the entire global health system. So there has to be somebody who's in charge of taking the 10,000-foot view and seeing what is working and not working well, because we know that it's not just governments or WHO, it's an entire very complex ecosystem of state and non-state actors who together jointly produce health outcomes or disease outcomes, which may be more accurate. And in order for WHO to be able to play the stewardship role, it does indeed need that degree of independence again from all these different stakeholders in order to be able to have a clear-eyed and arm's length view. At the same time, we need WHO to be politically courageous, and that rests a lot on the leadership. I don't think that's something that can be legislated at the end of the day.
What do you have in mind, Björn?
There's not much to add, so I fully agree with Amanda as well as Suerie. I think the first answer would be a WHO that really plays its role as the guardian of public health and global health, a leading and coordinating agency for global health, the leading authority, I would say, an actor who engages and is able to lead practically everybody who engages in public and global health. So that is also has the possibilities to engage with everyone, but not only on paper. And I think that's more or less the tricky part here. So someone who is leading and coordinating and has the capacities technically, politically, and financially to play these roles and to fulfill the world's expectations. And I think we will, in our further discussion, potentially address this, at least from our point of view, discrepancy in between what the world expects from WHO on the one hand and what it can fulfill on the other hand. And there's a major gap in between, which needs to be addressed in this reform agenda or strengthening of WHO agenda. And I think, so there is a discrepancy between what is written on the paper and what is the reality.
It's interesting that all of you are, talking about independence, really a strong focus on independence, WHO being a leading authority. I just, there have been a lot of proposals that have come out, but one of them is actually, and recently with the Independent Panel for Epidemic Preparedness and Response, one of their proposals was actually allow WHO to publish information on outbreaks immediately without countries' approval. I wanted to direct that, I guess, to Suerie and ask, how can we, how can we move with that proposal? What needs to be done there?
I think that's one of many very specific and concrete proposals that the independent panel put forward that underscores this broader theme of WHO autonomy from member states, or at least a certain degree of autonomy. I think that in reality, no matter how much we, for example, may reform and strengthen WHO financing and governance, WHO cannot actually just turn around and willy-nilly publish information that is highly sensitive about a member state without engaging in some degree of consultation and diplomacy. I'm not sure that that's actually realistic. And that's because one of the key assets that WHO has is actually trusted relationships with governments around the world. And a really fast way to undermine that trust is to turn around and publish information that governments don't want you to publish. So I do think one of the interesting questions that comes up about information sharing is, what are the other channels besides relying on these interstate mechanisms that might get information out faster to the world at large, that can complement what is a hugely important and irreplaceable intergovernmental process. But that intergovernmental process, I think, is necessarily going to have to move a bit more slowly than, let's say, the digital era may allow us to move, as the independent panel, rightly emphasized. And so some emphasis on technology and data scraping and non-state actors sharing information, I think, is really interesting if we can look at that as a way to complement what WHO needs to do at a government-to-government level.
There's another linked proposal to that as well, sending experts on short notice to investigate outbreaks. And we've seen, with the COVID-19 pandemic, how long it took to negotiate that kind of access in China, for instance. Amanda, do you have any ideas how realistic that we can actually move with that proposal?
Yeah, well, I wanted to just add on your last question for a second, and that is that we can't imagine that some of the other players in the system could create better incentives for putting data series in the public domain as a matter of course that would enable some spotting of anomalies, even if it's not officially reported by people at large, right? If you can imagine that, and this doesn't work for the Chinas of the world, but if you're reporting respiratory illnesses and flu and all of that on a weekly basis, the way the beautiful UK and European data sets do, and you can just go there and check and you can see exactly when this problem started to rear its head. So just to say that we might think of other ways to promote sort of routine data sharing that would enable that doesn't require like an official to acquiesce to share certain kinds of data. On your question, remind me what your question was again about IAEA type inspection possibilities. I think this would require some kind of a pandemic treaty or a revisit of the international health regulations. I don't think it's a bad idea, although it does suggest that one would have some routine intelligence function that would be collecting these unofficial sources of data. And the question is, when would you have cause to invoke such an inspection? I find it hard to imagine that the Chinas and the United States of the world will agree to this, but I think it's not a bad idea. So we'll see how things evolve. It was managed to be done by the IAEA because it was considered such a major communal threat that it was worthwhile to be able to do these kinds of things. Although so far, we know where those kinds of inspections occur, right? They occur in countries that don't have the possibility to resist it. So it requires a lot more thought, sort of what is practically possible.
You mentioned about, whether you asked the question whether the US and China's of the world will actually agree to this kind. I wanted to ask Björn, will the Germany of the world, agree to this kinds of proposals? You agree to have independent experts shortly right there, to investigate if there's any outbreak that comes in Germany?
Well, let's put it this way. I think, whether it will be possible in the very end to have the world agree to a new mechanism that allows for on-spot inspections, I don't know, on short notice within 2 weeks, let's say. I don't know. We will see whether that's possible. Whether the German government could agree to that, I think this is one of the key things that we believe could be in any mechanism for the future. Indeed, we believe on-spot inspections should be possible through WHO, obviously involving then a trustful relationship with the relevant member state. Certainly, that is one lesson to be learned. It should be possible for WHO. If WHO is supposed to play the role as the guardian of public health, then WHO needs to have these possibilities in hand. How realistic it is in the end to agree on such a consensus, we'll see. Obviously, there are voices against this, because this obviously also always infringes to some extent state sovereignty. But what do we get in the end, all of us? And I think we need to be thinking more creatively regarding incentives. So what do we buy through our more or less state sovereignty investment here? And that is, we buy ourselves a safer world, obviously, if that happens somewhere else. Certainly, this is always tricky if your own country is involved. I think then there's always a change in perspective. And I guess that does not only apply to the Chinas and the USAs of this world, but practically to all of us. And we have to be realistic there. But that is not to say that we should not agree to a new mechanism allowing this on paper and then putting pressure on the one member state that is facing an outbreak. I think I would like to come back to what Suerie also said with regards to the balance. We have to strike a right balance of autonomy on the one hand of WHO, which is a member state driven organization in the end, and the trusted relationship. And obviously WHO has always different hats on. WHO normally operates in a world where it has a country office and engages on a day-to-day basis with the health ministry, potentially even the heads of states in specific cases. And then really, I mean, the greatest value of WHO is this large network of country offices where it has this trusted relationship. And that we shouldn't put at stake. But on the other hand, when it comes to an outbreak, obviously there are different interests here with regards to the one member state that experiences an outbreak and with regards to the 193 other member states who have an interest in getting real-time data and an objective view of what happens on the ground. And I think we have to balance that out. I doubt that inspections is the only solution here, yeah, but it's part of the solutions.
Thank you so much. One of the things that happened, with a recent investigation in China is the trust that was placed on that investigation. And we know there have been a lot of questions, regarding the report of the international experts. How do you build trust as well in these kinds of investigations? That kind of helps as well the WHO in kind of strengthening, building trust in the organization as well. Anyone would like to jump in on that?
Probably others are more qualified, but I'll stick my spoon in. I think, having a very clear protocol, an evidence-based protocol would be one way to handle this. And I think the practice of having a roster of very highly respected, well-known, well-accepted scientists and social scientists as part of the team, that the whole set of countries could kind of authorize ahead of time. Those might be some ways to reduce the heat when it comes to the moment of the inspection, because they will have already agreed to the way it will be done and the individuals that would be part of it. And we should learn from I was looking at OIE, which is the UN Organization for Animal Health, and they do these inspections all the time, and they have sanctions associated with failure to disclose data. And those sanctions also have kind of consequence in terms of the action of countries that import animal products from those countries that are having an outbreak problem or a data disclosure problem. So it seems to me that we have a model that we could look at that might give us some practical ways to go forward.
If I could jump in on that point, I think Amanda raises some really important points about looking outside the health sector, or at least outside the human health sector, for examples, not only animal health, but in terms of weapons control, also environmental crises. We know that in other regimes, it's actually considered normal. And it's kind of a widely accepted international norm to have, for example, international inspections, sharing of data, sanctions. I think one of the things we've really suffered from in the health sector is a hesitance, and I might even say a nervousness about using international law, binding international law, much more. And I think many people watching this will be familiar that in the health sector, we basically have the Framework Convention on Tobacco Control, we have the IHR. We don't have a whole lot else in terms of binding international laws dedicated to the protection of health. And so this is really something that I think we have to overcome, and we can get a much longer discussion as to why is that, but there's a lot of lessons to be gleaned from elsewhere. And I do think that if we can come to a point where agreeing to an international inspection ex ante, far in advance, becomes the norm, and it doesn't mean that you've done something wrong, and it doesn't mean that you've violated trust. That the trust, it's too late to build trust in the moment of crisis. That trust and those relationships and those norms have to be established in advance, and that's what I hope we can do with the window of political opportunity that's open now.
You mentioned, Suerie, about, and Amanda as well, looking outside of the health sector. I read recently the report of the working group on sustainable financing. And, one of the things that caught my attention is there was a presentation by Gavi and I think it was the Global Fund, if I'm not mistaken, and just presenting how they're funded and their replenishment. I want to just ask Björn, perhaps, at what stage are you in this whole discussion of sustainable financing? Are there already concrete proposals that you can perhaps give us a bit of some examples that came up in your discussions as chair of the working group?
Thank you, Jenny. Well, to be honest, there are concrete proposals, but not coming from the working group so far. So we haven't moved that quickly. But maybe to put this into the broader picture, what the working group tries to address is indeed this discrepancy in between the expectations that the world has vis-a-vis WHO and the given abilities, the capacities, the financial capacities. And it's currently, I assume the broader audience knows that WHO has a budget of roughly 5 billion, but it's to a large extent funded by voluntary contributions, by highly specified resources, and only currently, below 20% of its funding, of WHO's funding, is predictable. So WHO practically plans on a 2-year basis, and they don't know whether they will be able to run their programs. They run short-term contracts, people even in the emergency program. And we all know Maria van Kerkhove. She just received a long-term contract because to a large extent that's the human resources model that WHO needs to run due to the unpredictability of finances. Yeah, and on the other hand, while we all applaud WHO and we highlight its leading and coordinating role and normative functions, etc. But for some reason, member states so far only contribute very, very limited sustainable finances. And that's been the issue not only recently, but for the past decades. And the trend has been growing. So practically the unpredictable voluntary resources have been growing, and the predictable, long-term funding, primarily through the membership fee, has been stable for the last decades. And the sustainable financing working group tries to address that. And we have in our mandate very clearly pointed out that we are supposed to look whether there are specific essential functions that should be funded no matter what, which should be seen as a priority and should be funded through the limited sustainable finances. And the rest would then be funded through other mechanisms. And this is where we are currently looking at. That we will have our 3rd meeting in June, so following the World Health Assembly, and I expect that especially through the launch of the different reports, and in particular the report of the IPPR, the Independent Panel for Pandemic Preparedness, there will be a new momentum and a new dynamic also with regards to sustainable financing. And that is also the one body that has produced a very specific recommendation. So the IPPR says the way, and this is also, we had the IPPR and also the Global Preparedness Monitoring Board and all the other panels present in our working group, and there was one common line that they all had with regards to sustainable financing, and they all said that the complete system is rotten. So you shouldn't try to reform a small bit here and a small bit there, but you have to bring in the broader picture. The way member states are currently, or we all finance WHO, doesn't make much sense to them because it's unpredictable and it makes it very, very hard to adapt to emerging challenges and outbreaks, obviously. Just to give you a sense, the emergency program, for example, is only 1/3 financed. The contingency fund that was created after the Ebola crisis that is there to allow WHO to more or less extinguish the fire without prior need to beg for finances has never reached its financing goal, is chronically underfunded with only a very limited donorship. So all these things are the reality for WHO, and still WHO manages quite well with regards to what the real de facto abilities are. So the IPPR says the entire core mandate of WHO should be financed in a flexible, sustainable manner. They are arguing in favor of a substantive membership fee increase, I think by 2 or 3 times. And the rest, the last third, should be financed through a replenishment model. And this is, I think also why it was quite interesting to invite Gavi and the Global Fund, because they obviously finance themselves fully flexible through a replenishment model. So this is where we currently are. And I think that after the World Health Assembly, we will be inspired by these recommendations, and there is the possibility that the working group will look at these specific recommendations coming out of the panels.
I think one follow-up is that, it's not just the independent panel. A lot of different experts have already expressed, how to fund the WHO is actually increase assessed contributions. So why not just take up that call by different experts, not just the panel, for member states to increase their assessed contributions, which has not really increased for quite a long time now.
Well, indeed, because there is a general trend among member states, and that does not only apply to WHO, and that is called zero nominal growth. So many member states have stick to the policy of not increasing their membership fee to any of the UN bodies. So this is not unique to WHO, I guess. However, currently COVID shows us that WHO is chronically underfunded or not receiving the right funding, and also shows us how important a well-functioning and well-staffed WHO is, and that the world just cannot afford a WHO not to be empowered. Yeah, and I think we also in these overall debates, obviously an increase of assessed contributions by 2 or 3 times sounds huge, and they are huge, obviously, compared to past levels. But if we are comparing this to the broader picture, what we are currently, the entire world is currently investing in the response and the recovery, I think someone said it's considerably nothing. It's almost peanuts. Just to give you a sense, if we are looking at the membership fee of WHO, what 194 capable member states contribute and provide to WHO through their membership fee per year, and if you look at that per world citizen, what we are investing into each world citizen through our membership fee of WHO per year, it's 6 cents per year. And the question is that sufficient to staff and to equip WHO right? And I guess we all share the answer no. We have to invest more, and that investment, I think that's also a key message that we hear from the IPPR and the other panels. This investment is a great investment because it allows you to invest less into potential further outbreaks later on, or needed recovery investments later. So compared to what we would need to invest, it's a great investment.
I wanted to throw in, the question as well to Amanda and Suerie. What other options are out there really to help address the funding challenges of WHO?
So I think one thing I would say is that it's not just a funding challenge of the World Health Organization. It's a funding challenge of the function of preparedness and response to infectious disease outbreaks in the countries of the world, first and foremost. And so when you look, many countries do not have the kinds of surveillance systems that enable them to even know how many people are dying. And I think when I look back at the enormous investment in HIV/AIDS, for example, we've had 25 years of HIV/AIDS investment, and yet the countries that are the most affected are not able to accurately count the deaths in the same year period from HIV/AIDS. Okay, and that's not for lack of money in some respects. It's about what we think is important and trying to drive to results. So I am, I think part of it is a financing issue, because of course, developing a good vital statistics system is very, it's a hard work, it takes time, it takes money. But I also think the key point is to the results that we want to see in terms of global health security and preparedness, that those standards are set and that the financing works to achieve those results. Because, how can it be really that this is, a previous pandemic that we still haven't got a handle on, and that this is part of the answer. I mean, I think the assessed contributions have to go up, and there's probably appetite for that. It's from 1 billion to 4 billion between all of the countries that are members. We can probably do that without a huge lift if we follow the independent panel's reports. But we have to see the current funding situation of the WHO as an expression of the lack of confidence that the member countries have in the organization's ability to deliver certain kinds of results. And so there is, it's not just a money issue, it's a leadership. I was happy to see that the independent panel also talks about the importance of merit-based recruitment, potentially of simplifying the levels of bureaucracies. There are more assistant director generals now at the WHO than at any time in the past. There is still a piece that's about kind of efficiency, about making it a science-based organization, and about delivering on some key mandates very clearly. And that, that is why we see so much ad hoc giving to the WHO. So the question is, can this replenishment idea meet those needs of the donors? But it's not so much meet the needs of the donors, it's can the organization deliver on these things in a way that is credible and that is observable in the public domain.
Suerie, do you have any thoughts?
Yeah, I think the my concern over the years has been actually less about the total amount and more about the way in which the money is structured. And I think that when those who have money tie strings to it, when they earmark it, it's not just about wanting to see certain efficiency or results. I think it's also about control. And different funders want to control different things. Some governments or non-state funders care a lot about certain diseases or efficiency, or having, let's say, somebody that they know and trust, let's say your own national in a certain staff position. Every single government wants their in, right? You want your in WHO. You want a way to get access to information and influence decisions and be able to pick up the phone and call somebody when maybe there is a suspicious disease outbreak happening in your territory. I mean, there are lots of reasons why governments and others want to influence WHO, and money happens to be a way in which they can do that right now with the current system. And so I think, we all began this panel talking about the importance of independence and autonomy. Money is one way in which to strengthen that. To me, what's interesting is that it's one of the few reliable ways to do that. It's actually low-hanging fruit to implement, whether it's the 20% to 2/3 jump in earmarked, unearmarked assessed contributions or another move. It's actually feasible, right? There are lots of questions about how to make WHO more independent, better technically, et cetera, that money cannot solve. But here's something that we actually can solve. And so to me, what's frustrating is that indeed we've been talking about this for 20 years. There is huge consensus. After Ebola, there was actually, this was put on the table. Let's increase these assessed contributions by just a little bit. Björn will remember the exact numbers. And member states should know. So I don't think it's about money. I don't think the efficiency questions purely answer, what's going on here. I do think that at the end of the day, everybody wants a bit of control. And so how do we move past that mentality, right? How do we move past member states and others saying, we all want our little piece of influence, our little pathway to influence into this organization, which plays a hugely important role. And for me, one of the weaknesses of the replenishment proposal that the independent panel has put forward is that Gavi and the Global Fund are financing institutions. They're not norm-setting institutions. And this is a very, very different function that WHO is asked to play versus these other entities. And that norm-setting function, in my view, has to be ironclad protected as much as we can possibly muster in the way it's financed. And I'm not convinced that replenishment is the way to do that. But I mean, I take the point that that's a way to mobilize, every few years, a lot of energy and excitement about the organization. But I think we have to think very carefully about how is this a unique intergovernmental organization that is different from any other global health initiative out there.
Thank you so much. I think we don't have much time. I would have loved to ask more questions to our panelists, given the large proposals out there on strengthening WHO. But really interesting because we have, I think everyone unanimously wants, an independent organization really. But there are factors, there are factors that are at play. It's not an easy road to just, implement all of these proposals. But hopefully the World Health Assembly will be able to move forward with some of them. I'd like to thank our panelists, again, Björn, Suerie, Amanda, for sharing your insights with us. And I'd like to invite our audience to please continue to watch our series of events during the World Health Assembly this week. Thank you so much and have a good day.
Hi, I'm Kate Warren, Executive Vice President at Devex, and I'm delighted to welcome Johanna Mercier, who's the Chief Commercial Officer at Gilead, to discuss how pharma can play a role in expanding access to medicines globally. So Johanna, thank you so much for joining us today.
Absolutely, thanks for having me.
So in today's program, we are taking a look at the future of health systems, and it is estimated that some 2 billion people do not have access to modern medicine. And as COVID-19 crisis is made more clear than ever, expanding access to medicine is a critical component to advancing health outcomes, during this pandemic and beyond. Gilead has been involved in global health since the early 2000s, I believe, when you made your first HIV drugs available globally. So Johanna, how do you see pharmaceutical companies like Gilead's role in advancing access to medicine in low and middle income countries?
I think it's a really critical role, actually. It's a challenging one nonetheless, but a very critical one. And I think, I can only speak for Gilead Sciences, but I do believe that it's across the industry. It's one thing to discover, develop new medicines and innovative therapies, but if it doesn't get into the hands of patients that need them, then we've failed. And I think it's an incredible opportunity for us to make sure that we're not just thinking in the developed world, but also the developing world. And I think Gilead Sciences was able to accomplish some of this just most recently with remdesivir in the last 12 months or so, because of the experiences that we'd had before that you referred to in HIV, for example, but also in HCV in low and middle income countries, as well as the developed world.
Yeah, and so, thinking about your past work in HIV treatment, how did that help inform your approach to delivering access during COVID-19? What were some of the common barriers you've seen and ways that you've been able to try to overcome them?
Yeah, I think that our mandate with remdesivir was obviously first and foremost quite the challenge, right? You had to ensure that this medicine could actually have impact for COVID-19 patients. And so there's a lot of work being done from a development standpoint. So we had a full development work stream working through to understand not only, activity versus in vitro, but also activity then in humans, right? And understanding that through clinical trials that we started, some in China, and then of course in the US followed very quickly thereafter. So there's a lot of work going on clinically, and we can go into detail if you'd like on that front. There was also enormous amount of work from a manufacturing standpoint. And the reason for that is end-to-end manufacturing of remdesivir was originally 12 months. And we knew that we didn't have 12 months. And so if this was going to be an efficacious and safe treatment for patients, we needed to try to streamline the manufacturing process. And so there was a full team on that. And I would compare that as kind of a lot of kudos to the manufacturing team, but it was basically you're flying the plane and you're building it as you're flying it. And how do you streamline? Because some of the chemical reactions were actually sequential. And so you couldn't cut down that time. So you really had to think through where could you accelerate? And we were able to, the team did an amazing job and actually bring it down all the way down to about 6 months, which really helped from a supply standpoint to accelerate supply. All of the work I just described from a manufacturing or development standpoint was actually done at risk. We didn't know yet if we had a product in COVID-19 patients, but we felt we had no time to lose, and that if we were to have a product, then what we needed to do is get it out to patients. So as things were moving forward, we also understood that it was going to be challenging in the developed world, and that COVID-19 was not being picky about who it decided to affect, which countries were affected. And we're seeing that still today in many countries around the world. And so it didn't matter if they were richer countries, poorer countries, south of the equator, north of the equator. I mean, there was a lot of assumptions that were done early on that were wrong. And I think everybody, unfortunately, this has been truly a global pandemic. One of the things we knew was and it's not just we knew, we had a goal. Gilead had a very clear goal that it was about access and affordability. And it goes back to my earlier statement that if you're going to work on a medicine, you don't want just a few people getting that medicine. You want whoever is appropriate for that medicine to get the treatment they deserve. And so the philosophy was no patient is left behind. And that's exactly how we leveraged a little bit the work that was done in the past through an incredible team at Gilead that really focuses on the developing world countries and what they had done in HIV. And what they had done both in HIV and HCV is basically leverage the technical expertise, transfer that technical expertise to generic manufacturers in certain countries like India, Pakistan and Egypt are examples with remdesivir, to make sure that they can ramp up supply. So there was two goals for this. One is we knew that not just Gilead on its own, despite all the partnerships that we had around the world, including pharmaceutical partnerships, we weren't going to be able to ramp up fast enough. And so there was an incredible opportunity to make sure that we leveraged all the different sources that we could actually see potential for ramp up. And so by doing voluntary licenses with these generic manufacturers, and these are very similar generic manufacturers that we leverage, that we have relationships with from our HIV, HCV days. And so there was an opportunity to give that technical expertise, show them how it was done, and for them to basically ramp up their own manufacturing and supply, the generic remdesivir, in those low income and some middle income countries, so that many of those, because there were multiple generic manufacturers, they competed on price, and the price obviously was able to be much more reasonable and much more in line with those markets and what they can afford, right? And so that's how it played out. And I just want to add one piece, and this is in my first year at Gilead as we're working through this. I was just amazed. I mean, we did this with no royalties during the pandemic, and the intent was really around, here's the supply, ramp up the supply, and ensure access to all those patients that will need remdesivir. So that's how we leverage the HIV, HCV learnings, but also the team that pulled this together was really impressive. And a lot of them had been on those work streams in the past for HCV or HIV, and we're basically pulling it through for remdesivir.
Yeah, I think that's a really interesting point. And this voluntary licensing has, I think, been proven to be a very effective method for expanding access for the points you just raised. Curious to see how you think local manufacturing capacity could be boosted to continue to reduce low and middle income countries' dependence on imported medicines, ramp up that capacity of local manufacturers. What are you seeing effective methods for approaching that?
Yeah, I think you always have to find the balance of what makes sense, right? Because you want to make sure that you have enough generic manufacturers that are involved, that you have the right generic manufacturers, because there's a quality piece to this as well that is really important. And it's also one that, the contracts that we have with them are specific to about 127 countries around the world that they would supply if needed. And so I think that there needs to be certain guardrails. There's no doubt about that, or else I think then the development of new medicines would be at risk. And so I think that's an important piece of the puzzle. But I also believe that, you have to be conscious of healthcare savings and making sure that it gives back to the system so that it becomes a sustainable model moving forward. So I think sustainability is really important here, is how you think about it and who and where you go to support this. And, I also think that it might work for certain medicines versus others, right? I think some medicines that are, sometimes if you think about, depending where the countries are in their healthcare, some medicines might not be appropriate at this point in time. It really depends on the healthcare framework and system that they operate in. So I think we just need to make sure that, we customize a little bit how we approach different systems, and we help the people that want to be helped, right? And so it's really about making sure we partner with governments, we partner with institutions. It's not about doing this ourselves. It's about, the expression about teaching somebody to fish and they'll eat for, the rest of their days. It's kind of the same concept, is how do we partner together with these countries to get to a solution? One of them is voluntary licenses, but there's a lot more than that. And Gilead Sciences is very involved in just starting from the basics, which is education, especially if you think about HIV. I think that plays a very important role if you want to end this epidemic in HIV. And so it's really bringing different pieces of the puzzle together, I think is important. It's not just one thing.
Yeah, I think that's a great point. And, in our audience today, we have many global health professionals working with governments, NGOs, multilateral institutions, health tech startups. And so, how do you work with these various stakeholders, and what advice would you give to those tuning in today as to how they could help in these efforts to expand access and how they could engage with pharmaceuticals like Gilead?
Yeah, I think Gilead's engaged with many of them. There's incredible connections, and we've learned so much, and I really talk about partnership because I think it's important. It's not just one company or one NGO, right? It's about coming together. And I know that takes a little bit more time and sometimes a little bit more effort, but the outcome is just so much greater if you work together. And I would even add academic institutions, right, from the WHO to like bigger foundations as well. Like there's so many different pieces of the puzzle that can come together. I do think that when there's a will, there's a way. So I think that's an important piece of the puzzle. And, I think about even just what just happened most recently in what is happening currently today in India. As you think about the incredible crisis that they've been in for the last few months now, and how different people, they leverage their embassies to kind of reach out to different folks across different countries to try to get access to oxygen tanks, remdesivir, other medicines, vaccines, et cetera, and what they needed to do. And, through discussions with the Indian government, we were able to kind of move pretty quickly and do a couple of things. One is, within about 4 days, to be honest with you, a small team of us came together and we basically defined, okay, how much product do we have? How much can we send? How quickly can we get it there? And I think that was the biggest issue, is transportation, by the way. It was actually one of our challenges, was to define a donation of 450,000 vials of remdesivir to get it out to India as quickly as possible. And of course, working with the government very closely for the import licenses and all the paperwork that needed to be done. We turned that around in 4 days. And, I'm super proud of the team on that front, to be honest with you, because everybody had the same goal, was to help. How do we help? And it was extremely powerful. And I saw so many other you talk about, the different folks on this call, so many people were like, how do I help? What can I do? And everybody kind of came together on that front in different ways. And there was different opportunities to help, and including other pharmaceutical companies, to be honest, that were less closely linked to COVID-19 treatment or vaccines. And so I think that's extremely powerful, how we can come together. The other thing that we did is, obviously, we knew that the generic manufacturers in India that we had a voluntary license with, there was 7 of them, had slowed down their manufacturing originally because they didn't think they would be in this situation. And so they were ramping up. And as I explained earlier, the manufacturing of this product is a lengthy process. And so what we also did is, how do we help them? How do we help them accelerate their process? How do we give them potentially API, active pharmaceutical ingredient, to some of our voluntary licenses to kind of speed up and ramp up that process, and make sure that not only India gets served, but making sure those 125 other countries don't get lost in this mix and also have a challenge getting remdesivir. So I think all of those pieces were super important, and I think appreciated. And I think that it was incredible to see how a lot of people came together, governments came together to give oxygen tanks, to give different medical equipment and treatments that the Indian people really needed and still need to this day. The ramp up, we feel now in India, they should be in a really good position by the end of the month. And we've also seen the numbers come down, thankfully, which also, both of those things kind of help the whole situation. But I would just say, like, those are the kind of things that we can come together and partner. And we've had so many emails that we actually had a bit of a customer-centric approach on this one to make sure that no email got left unanswered, and anybody who wanted to help got brought into the mix. And so to your earlier questions about how can we, I think in times of crisis, not just the industry, but all our partners come together so beautifully. It's impressive. And I wish we could do that on a more day-to-day basis, to be honest.
Yeah, well, let's hope that can be one of the bright spots of this, is the lessons learned heading into the future. Well, thank you so much, Johanna, for taking the time to share your experience with our audience today. I know I learned a lot from the conversation, as I'm sure those listening in did as well. So thank you.
Well, thanks for having me, Kate. And I just want to say, this isn't a one company thing. Of course, I'm sharing the Gilead examples, but I mean, as horrible as this pandemic was and still is, because it's not over until everybody's out of it, I do think it has brought a lot of us together and showed us what we can do and how quickly we can do it. Obviously, always based on science, but really driving that forth. And I just want to say thank you.
Great, thank you.
Hello and welcome to Devex's coverage of the World Health Assembly. This year is obviously a very important year, given what's happening with the global pandemic of COVID-19. And I have 2 people to help us think about what that pandemic has meant and where it takes us in the future when we think about the future of health systems. I can't think of 2 better people to give us this broad view and to point us in a new direction than Agnes Binagwaho, who is the Vice Chancellor at the University of Global Health Equity in Rwanda, and was, of course, the Minister of Health of that country, along with many, many other accolades and affiliations that she has, well known in our community here at Devex, and Prashant Yadav, who has also many affiliations, but is with CG Dev, the Center for Global Development, of course, and INSEAD, has worked with the Bill and Melinda Gates Foundation and others as a leading expert in the area of global health supply chains. So really eager to get into a discussion with both of you. Maybe we could just dive in on this issue of vaccine manufacturing and see where that takes us in our conversation, because we are right in the middle of big conversations on this issue. Prashant, you had a piece in the New York Times just a couple of days ago arguing that we need to really rethink the way we manufacture vaccines and where we place it. One of the countries where you said maybe a key hub should be is Rwanda. So maybe you could just dive in on where do you think we're going to go after this pandemic when we rethink the global health architecture and systems and where vaccine manufacturing fits in?
Yeah, thanks, Rajan, and honored to be here together with Agnes. And I think the key takeaway, what we've learned is a dependency on global structures alone for manufacturing and purchasing is useful, but not always sufficient. And we need perhaps multiple lanes in how we run the supply chains for health products, vaccines being one part, but also for medicines, PPE, other health products. And by multiple lanes, I mean we ought to think about some portion of the manufacturing occurring regionally that can cope both with short-term demand that may come up during the times of a health emergency or an outbreak, but in routine times it could serve other more routine needs, and couple that with purchasing from long supply chains for items where we have an established and also geographically diverse source of supply, where efficiency and cost are really important. And when we are thinking about the large cohorts in a country's population for routine immunization or for routine treatment programs for chronic diseases, then we may have to think about where can we manufacture that at such a large scale that we get the lowest prices. And that combination hybrid strategy is what we are seeing to be effective both for current pandemic, but also for being better prepared for a similar.
Well, for the next pandemic, but also for just, as you say, routine health needs in many low and middle income countries where vaccination is still a challenge. I think there's two issues coming together here, Agnes. One is you have the crisis in India, where there's such a massive manufacturer of especially AstraZeneca vaccine, which is meant for many of the countries in sub-Saharan Africa, and they're now stuck without it because India says we're keeping the supply ourselves for understandable reasons, but it's creating this huge bottleneck and challenge. And then we're all, waking up in a way to the idea that only 1% of vaccines for routine vaccinations in sub-Saharan Africa are produced there. So we're really starting to maybe rethink this system. And you've been thinking about this for so many years and studying it. What do you think we should be doing differently from here?
Everything differently. First of all, starting to believe that Africa has not enough capacity. The world has enough capacity, and there is enough plane and people to share and bring the capacity here. We have Cuba, we have China, we have Russia, we have how many countries in Europe and America, and I'm sure in Latin America also, who have scientists who can come in Africa for a couple of years, work and transfer capacity to African. Having the capacity of producing vaccine in Africa doesn't mean that we just want Africa in. Just doesn't mean that we just want a country to lead it. We want a regional effort with a global solidarity. And saying the contrary is just finding excuses not to make it. When we need to save life with peacekeeping, the world put all nationalities together, they put them a blue hat and they send them where there is a problem. We should do that for vaccine and scientists. Capacity is not an issue. Electricity, the continent can solve it because they can come together to divert electricity to produce. And as Pasha said, not only for COVID, COVID shows us that we need to do that if we want to survive the next pandemic, because Africa will be the last to be served. India shows us the problem now. And I'm not against India. I'm against the European and I'm against the American who just block this avenue. Second, saying that we understand so many problems, security, electricity, hesitancy, all those are fake reasons. The only true reason is the lack of willingness to make it happen.
It's interesting, in Prashant's argument, there's a lot of realpolitik involved because he's saying, let's move manufacturing from big countries like India, which will have an incentive to keep the vaccines in a crisis, to small countries like Rwanda, where if you can produce a massive number, more than your population could ever need, then you can export it to your neighbors. And one thing this pandemic has shown us is, of course, we knew about vaccine nationalism before, but boy, the way countries have locked down on their PPE, on their treatments, their diagnostics, their vaccines, there was a system, the WHO, the ACT Accelerator, trying to get past this. How do you assess that system? Is COVAX, ACT Accelerator, are the systems that have been set up now to address this sufficient? Is this the way we should be looking at the future?
COVAX is not funded enough. COVAX is a pretext for the rich country to sleep well at night, pretending they have done something. No, they did. Vaccinated 1% of a population is ridiculous when we know we need 60% minimum to have herd immunity, minimum. So pretending, we should stop to give room for pretending. Let's go for real thing. COVAX is not working.
What do you think, Prashant, about COVAX? What would you do with COVAX from here?
So I think COVAX started with the assumption that if we have money and pooled demand from a large number of countries, then we will be able to buy and fulfill that demand. The reality they find themselves in is it's not a technical problem, it's a political problem. And that political problem is that on one side, you may say, yes, they didn't raise enough money. But even if they have more money, there isn't much available in the market to buy. What will they buy? Because all of the supplies have already been taken up. So I think the next phase has to ask, in my opinion, two questions. One is, we cannot solve such problems without expanding manufacturing capacity. And if there is more manufacturing capacity, then yes, COVAX will be able to buy more, distribute more. But then the positive things that have come out of this, and this goes back to my earlier comment on multi-lane systems for procurement and distribution, that the AU organized itself through the Africa Medical Supplies Platform and was able to negotiate for members of the African Union quantities of vaccines which otherwise would not have become available to AU member states. And that effort is in many respects commendable, that you've organized and brought together a group of countries and said, we will create something which will take our common market and go to manufacturers, use our ambassadors and people who have the ability to connect directly with the executives of the companies and say, here is what Africa needs. If you want to work with us, this is how you work with us. So I think that's a positive development. And COVAX and such an initiative can work together. I mean, I think we need to think about at what levels do we need to coordinate globally? And that is information about who's buying, who's manufacturing, how much. For that, we absolutely need to coordinate no matter which mechanism is used to purchase. Purchasing and giving the actual purchase order could be done through COVAX, or if a group of countries creates its own arrangement like the AU has done, that's great too. What can be tricky though is if every country starts to go out on their own and start saying, okay, let me find what I can get for myself. And that can fragment the market into an equilibrium which will hurt everyone.
And where do you think IP fits into this, Agnes or Prashant? This has become a big debating point, a political point. Is this a key issue when you think about that future health system that you want to build? Should there be the vaccine manufacturing capacity and a system for licensing the IP around emergency vaccines? How do you think about that issue?
I think that the reward of scientific finding should be recognized. But we also, the public good should be. We all do that for human. And all those factories did that with taxes of individual like you, not like me, but like many people in their country. So they should give back to the world what they receive. But it's not that if you come and do a factory in my country, I should steal you. No, come and do the factory and let's produce enough. Like Prashant said, we don't have enough. Even if the world became reasonable tomorrow, we don't have enough because of the history, that it's a colonial history, but also a lack of trust in Africa that didn't develop the capacity of Africa to produce what Africa is needed. And what is requested here, it's not a country doing everything, it's the country working not alone with the continent to do and produce what the continent needs today and be ready for tomorrow.
Prashant, where do you think this issue fits in and when you think about the future of this?
So I think often what I'm seeing in this debate is that we are confounding the immediate with the medium and the long term, right? In the immediate term, we need to solve the problem of having more manufacturing capacity. If it can be done quicker in existing sites, so be it. But I personally believe that it can be done quickly, at least in a few additional sites, such as what we're talking about, in Africa, in Rwanda and Senegal. And if it's done quickly enough there, it may require the company who developed the process, who essentially mastered all the little steps in making the vaccine, to voluntarily say, I want to send my team to help the new site get up and running as quickly as possible. The fastest pathway to get something that is high quality, efficacious, process consistency will only occur when the originator company which developed the product says, yes, my team which has mastered the process will transfer that know-how. In the medium to long term, opening up IP to additional countries creates the opportunity that people innovate in very different ways. We think of innovation in sometimes a myopic lens of what happens inside a biopharmaceutical company, but lots of things happen when people are trying new things with it. So in the medium to long term, yes, IP waivers can help. But in the short term, I think it will come down to how can we create technical know-how transfer from the company which has developed the vaccine to additional sites. That may not necessarily require an IP waiver. That requires a stronger willingness on part of the company to say, yes, we'll do it. And secondly, we have to also acknowledge that some of the companies who've developed vaccines this time are not the ones who have a big staff or presence across the world. One company in particular, for example, is a relatively new biotech. So can we create a global enabling structure for them to say, I don't have to send my own staff. My staff can train somebody who can then go and create this capability in multiple sites.
It sounds like
the responsibility is not for the company.
A new institution.
Yeah, that is a responsibility for us in the global collective, not so much for the company alone.
And we have as I said before, we have skills in Cuba, China, Russia. So we can ask globally for the right people to come together and start. And I agree with Pasha. This has to start now to be productive in a couple of time. But now we have sites that are capable to produce more vaccine, and they are not allowed to. It's a crime against humanity to let Indians dying like that without trying to give them the capacity to produce vaccine for themselves. Most sites.
Agnes, let me ask you, because I started this conversation talking about vaccine manufacturing and supply, because that is very much where everyone is thinking now. Is there a chance we will learn the wrong lesson coming out of this pandemic and kind of go back to our old ways of vertical thinking, right? Now it'll all be about vaccines instead of thinking more broadly about the health system, healthcare workers, thinking about maybe cold chains or thinking about diagnostics. And are we missing a chance for a different vision, or what is your vision coming out of this pandemic? What should it be?
Like usual, human species is an amnesic species. We are not even now understand which country have done well and why, and countries who have done badly and why. So we have seen now that a country like Rwanda, where with $820 per capita, we have managed to stop the spread of the disease by, before the pandemic, building a resilient health system for the population, focus on decentralization and bring the care where they are, focus on multidisciplinary work, and focus on policies, law, and plan that are focused on the vulnerable. And this is what we create, what we call a resilient. We will see that, but I hope the world will learn about that. Also, the fact that nobody really questioned enough all those metrics and projections where it will go well and why and how, and help countries to be prepared because their projections are wrong. The global security index is so wrong that this institute should close, go to retreat, revisit his book, and come back with new knowledge.
And those risk profiles make a big difference because they determine interest rates and investment in a lot of the lowest income countries in the world.
And invest in the right thing, not invest where New York, London, Washington and Brussels believe we should invest. No, the lack of trust in Africa and the lack of recognizing what is going well in Africa, even European countries, there are thousands of people who die wrongly in Europe.
Prashant, what are your thoughts about where we should go? What is your vision of the future health system based on what we've all just experienced in this pandemic?
Yes, I think you're right in pointing out that there is too much attention on vaccines, and I think we ought to think about system levers, not just very verticalized one intervention. Alongside with vaccines, we have tremendous opportunity to do something differently in diagnostics. We can do a lot more diagnostics manufacturing regionally for a variety of different diseases, pathogens, and that is advancing and has advanced due to COVID, including in locations in Africa. The second is that a lot of interventions which were considered to be things which are solving one problem. Examples are, the work with the drone company in Rwanda and Ghana, Zipline. We assume though it's solving one
knows
problem.
Very well. I think signed the MOU for them to operate in Rwanda.
Now you realize by investing in an innovative systems improvement platform, you get the benefits of doing contactless PPE delivery, even vaccine deliveries to smaller sites where it's harder to deliver using a truck. And all of that helps us realize that system level interventions are a good bet because they can quickly pivot and help us when there is a health emergency. Another example is a company in Ghana called M-Pharma, which is pivoted and started doing a lot more private sector diagnostics to complement what the Ghana Health Service does in terms of diagnosis. The group that Agnes and others in Rwanda promoted called Babel, which allows teleconsults and other things, triage using technology devices that helps in triage. So I think those system interventions are what our focus should remain. We have learned that the Venn diagram of overlap between system interventions and how much benefit they create both for vertical programs and for health emergencies, that overlap is much higher than what we have imagined in the past, and COVID has demonstrated that overlap very, very clearly. So when we go back and reflect on this, those are things that we should keep in mind and remember.
Agnes, we have to wrap up. I want to get a final thought from you.
So I just want to say that I totally agree with Prashant, that what I have seen in my country and other country where we had studied what countries has continued to keep ordinary primary care and ordinary specialized care efficiently during the pandemic. Those are countries who simply implement the strategies of creating and managing and repairing a resilient health system. So you don't need to invent anything. You need to be capable to create a system that will respond to any threat. You don't know what is the threat of tomorrow. So create the system that's what I call, and we all call, resilient to day-to-day services for all age and any emergency that it comes, because you wake it up in a minute, the emergency before it's killing your people.
And I'll just underline something you both said, which is the pandemic has shown us how people can innovate and they can rise up to a challenge and they can move fast. And if we can set up the systems that allow that.
Absolutely, Babel, we have done e-health. Even locally, not only with through Babel, we have done e-education to keep education. We have done GPS on all the track to continue the transport between Tanzania, Uganda, Burundi, Rwanda, so that we can follow the track and even see where the positive truck driver have stopped to pee. We can go and do contact tracing around that place where he just went out of his car for a biological break. And we can do that. The drone, we use that for more than 5 years. Robots to go look at, give message, take temperature, take blood pressure, so that, and report also. It's the robots are reporting more easily on the follow-up of patient than a tired, insufficient health workforce, and it's so good. So there is a lot of innovation, and they should be used on day-to-day basis in the health sector we are going to have after COVID. COVID is just a step. COVID is just a wake-up call. It's just a disease like plague, like anything.
Well, I want to thank both of you, Agnes Binagwaho and Prashanti Adav, for giving us such an interesting look into where this may take us in the future and where we should prioritize. And I want to thank all of you who are following along here during Devex's coverage of the World Health Assembly. Be well.
Hello, everyone. Welcome back. I'm Vince Chadwick in Brussels, Devex's EU correspondent. I'm joined by Jenny Lei Ravelo in the Philippines for us wrapping up the end of day 3 of Devex's coverage of the World Health Assembly, although the stories keep rolling in, and they will over the coming days as well. Jenny, you're the co-author of our Checkup newsletter. We encourage everyone to subscribe to that to get all the latest updates as well about what we're hearing from the World Health Assembly. Jenny, you are a global health reporter. You're also based in the Philippines. And before we started, you were showing me what you have to wear when you go outside these days. Would you mind showing us, everyone at home, what your standard kit is?
Yeah, sure. So we're still wearing masks here. On top of that, we're wearing this face mask. So, you know, and if you're wearing glasses, you have like 3 things on top of your face here. So wow. Yeah, it's a tough one. Yeah.
Wow, and that's mandatory.
Yes.
Wow. Well, that's a vivid reminder.
when police force aren't looking, some people don't follow, but it's mandatory in most establishments.
Wow. Well, a vivid reminder of the fact that we're still very much in this pandemic. Even as we begin discussions about how to build back better. And one of the discussions has been about how the WHO, and we heard about it in our previous panels, how the WHO can be better equipped for future challenges. And one of the questions is this question of inspections. And I was interested, you asked Björn about the prospect of inspections, and so much of the focus has been on, you know, the likes of China being open to inspections. But you asked him, what about Germany? What did you make of his response?
It was interesting because, you know, there's been a lot of calls from this pandemic on, you know, for that to happen, doing inspections. The independent panel, you know, one of the recommendations was to be able to investigate on short notice. But it was interesting when he said, like, basically, we don't know yet if Germany is going to agree to that. And so, you know, it kind of makes me think like how this recommendation can actually move forward, because when you put a recommendation like that, you just can't select just particular countries. It has to be, you know, applicable to everyone. So that was interesting.
Right. Well, this will be something we can pick up again perhaps on Tuesday when we have a call for our pro subscribers around kind of wrapping up the World Health Assembly this year. I encourage everyone to sign up. Free trials are possible for a pro subscription, so really anyone can join us on Tuesday next week for that. I'll be looking forward to chatting with Jenny and some of our other reporters. Other than that, I just suffice to thank our partners, AstraZeneca, Gilead, HemoQ, Novartis Foundation, GSK, and Save the Children. And to say thank you all for being with us for our coverage over the past 3 days, and see you Tuesday.